everything's okay.
Perfect, thank you. So normally, from a surgical point of view, we see patients with acute abdominal conditions. Most of the times it's acute appendicitis as they present down to ED. And that's one of the most common admissions that we get in surgery. Sometimes, and that's why I say, and the taking home point from this presentation would be to keep an open mind, I think, just because sometimes we can get caught out, I would say. So, and well, if we're looking at the foreign body ingestions, most of the times we can see that in the emergency room, we see that 80 to 90% of the times they spontaneously pass through. However, there's a 10 to 20% risk of things that we need to retrieve with endoscopic intervention. Obviously, there's that 1% that requires our attention to excavate out from the GI system. Now, when we look at the causes, most of the times foreign bodies are accidentally swallowed by, unsurprisingly, by children, less than 3 years most of the times. Conversely, we see them intentionally being swallowed by elders as well. Most of the times, this intentional behavior is a repetitive ingestion pattern, and the intellectual and mental abilities of these individuals are associated with this condition, along with significant substance abuse and maybe psychiatric disorders or external motivations if the matter does arise. Now, until recently, medical and psychiatric literature did not focus much attention on the prevention of and the therapy of the behaviors associated with the repeated foreign body ingestion. This repeat foreign body swallowing may be part of a syndrome of self-mutilation and also attention-seeking behavior. Now, yeah, so one thing which is most of the times shoved under this umbrella term, Munchausen's, I think we should use this very, very carefully, because repeat swallowers are also diagnosed with this psychiatric condition of factitious disorder. I will point out here, make a point while we're presenting that I think this should be a diagnosis of exclusion until all our investigations have been completed. One should not use this syndrome for the surgical patient unless there is a reason for it. Moving forward, we discuss the trichotillomania and trichophagia. Telophagia, which is the hair pulling disorder. It's characterized by repetitive pulling of the hair. It's a group of disorders of body-focused repetitive behavior that is associated with self-grooming attitude and resulting in damage to one's body. Research indicates that 1 in 50 people, or nearly 2 in 50, would have and experience this during their lifetime. Usually begins in late childhood and early puberty. Children usually are equal in terms of sexual preferences. However, in adulthood, it's 80 to 90% of the time, it's mostly women involved in this repetitive damage to their body behavior. Now, this hair pulling varies greatly in severity and in location of the body in response to the treatment. Trichotillomania becomes a chronic condition. This is a bezoar which sits in the stomach. As you can see, it takes the shape of that stomach where it sits. Because it's repetitive and it stays for a long time. One of the characteristics of this condition is that the hair is non-digestible by the enzymes of the body. And because of the shaft is more smooth, so it resists the peristalsis. And eventually, because of the blunted ends, it gets trapped between the mucosal folds. In a nutshell, it's very difficult to get rid of that body of bezoar if it is present in the stomach. As you can see, it took the shape of the stomach. That is the body of the bezoar, and this is the tail, which is going toward more distally in the GI. So it's taking the shape of the pylorus, the duodenum, and sometimes it has satellites going down to the terminal, all the way to the terminal ileum. So yes, moving on, the management of this condition protocols to the foreign body ingestion depends on key factors. First of all, the type of bezoar, the shape and where it's located, the different types, which we'll discuss further as I go through. The symptomatology associated with how the patient presents. They initially, if children usually present early because the parents would have noticed, or they start to produce symptoms. However, if the repetitive behavior in adults, they usually have chronic GI symptoms like reflux disease, subacute bowel obstruction, and this is something that are mostly shoved under the carpet, that is a repeated attender. We might just want to, just label him as Munchausen, which I would still be quite aware of when someone uses that term. Having said that, moving forward, the time elapsed. So early ones, the accidental ones usually early. The one with the repetitive behavior, usually chronic ones for a longer duration of time as they present, and the complications that one presents with eventually. So medical, surgical, and psychiatric evaluation should be part of the whole bundle, and it should be part of the package that we would be offering in someone who we see foreign body ingested in them. So this comes to our case. This is a it was an interesting one because it can take you by surprise unless you have an open mind to these things. We present to you is 37-year-old lady who presented to ED with quite clear signs of acute appendicitis, migratory pain starting in the center, radiating the right fossa, quite typical of how it presents in our medical textbooks. So between 18 hours, it does localize, gives you signs of localized peritonism, and does not give any, she never gave any preceding history of GI symptoms or urinary symptoms. In the past, I think she had a miscarriage in the past. Other than that, she was fit and well, worked as a vet. Clinical examination revealed tenderness in the right fossa, which was quite noticeable, and symptom-wise, she started to behave in a febrile way with slight temperature. So the septic 6 was initiated, and we did some routine blood workup showing a raised white cell count there, along with a CRP, which shows that there's signs of infection, and hence we need to do something about it. Furthermore, the time before this and surgery was nearly 6 hours. Could have been sooner than that, but there was more traffic in our CPOD list, so we did manage to take our time. During this time, she had a blood gas workup. Again, it was showing that there was lactate was creeping up to 2.1. She was given IV antibiotics. She was given analgesia. A drip was put up, and she was prepared for surgery. Now, we did a standard approach, laparoscopic diagnostic laparoscopy through our port side. This was the optical port here, and 2 ports in the right side, in the left side, sorry, for working ports. And there was an inflamed appendix, I would say. These are small pictures, not great pictures. They're mostly dark here. So in this picture, you could probably see that this is a strand of hair that we were plucking out from the base of the appendix. Now, as we cut the appendix, it does sort of, it starts to part of this hair fibers was trying to escape out from there. So we had to take out all the hair out from it. Now you can see in further images here that these hair strands are being pulled out from the tip base of the appendix as we're cleaning it up. And this is a white Burt bag. That's the bag for retrieval of tissue. So the appendix that we removed was placed in this bag along with the hair that we were pulling out from the base of the appendix. Now this, as you can see again, there's a lot of hair that we just had to pluck out from there and pull out from the cecum, and we were pushing it back in the bag over there. You can see some hair, some bezoar over here. So now, eventually, we put a ligature on the base of the appendix, gave a washout, put a drain there. She behaved slightly septically during the operation, and which the anesthetist was, he made us aware of. And eventually she was managed in the level 2 care in the high dependence unit for the first 3 days. She did really well, responded to antibiotics. We took the drain out. She was later discharged on the 5th post-operative day. On the 2nd post-op day, I did speak with her. She was conscious oriented. She was fine. I did show her the pictures and said that this is what we found, because we never realized that this is something that we could have found while retrieving the appendix. Mind it, at the same time, we also milked small bowel to see if there's any other satellites there, which I'll talk about further down. And I also wanted her to have a gastroscopy, which I will also discuss why we need to do that. She confessed that she does have this problem. She swallows hair, she chews her hair, she works as a vet. Sometimes she even swallows wet animal fur. So this is something which she did admit to in the end. So moving on, as we discussed this case, and then we presented this in one of the journals. And the origin of this bazaar comes from two words from Persian and Arabic origin, respectively, from bazar and bazar, mostly denoting antidote. And it consists of hairball or hair-like fibers that's being chewed and swallowed at this time, along with indigestible substances. They usually form in the stomach, as in the prepyloric region, as you could see in that picture that I'd shown you earlier. And eventually that nidus certainly forms bigger, and it does not move a lot. Only the one at the distal end starts to move slightly more, and it starts to form distally as well. The origin, obviously, from Rapunzel syndrome. Rapunzel was one of the German princesses in Grimm's fairy tales. She let her long hair down to facilitate a tryst with her lover. So that's how it originated the name Rapunzel, because of the long hair. So there are 6 different types. The one that we saw was trichobezoar. There's phyto, litho, pharmaco, plastico, and lactobezoar, different kinds. And that's why endoscopically it is important to identify the type, and management depends according to the type of the bezoar that we find, as we mentioned earlier. So in literature, when we reviewed literature, we found that it was in 1968. It goes back to 1968 when it was first reported by Vaughan as a disease, and the 30 cases noticed then in literature. And he characterized these findings about the description for someone to give you a Rapunzel syndrome. Hence, the body of the trichobezoar, which is ingested in the body with a tail that can be found in the intestine, which may or may not cause bowel obstruction, could be a subacute. It occurs in psychiatric patients who exhibit telomania. Now, trichotillomania. Now, we must, however, note that these characteristics were hidden in our individual patient that we are discussing. However, she did eventually say that she had epigastric pain in the past, but did not have a lot of that once we spoke to her about it. Now, in the later stages, because we say that, yes, they don't present acutely, there would be a chronic abdominal pain. Now, this will be caught out, stomach ulcers, perforation. This is when it does cause bowel perforation and bleeding. That's going backwards. Once you diagnose it, then you go backwards to what the cause for this was. Eventually, you will get caught out unless there is a clear idea of what you're dealing with there. However, most of the time it's chronic abdominal pain, which again is shoved under the carpet, and patient is diagnosed as Munchausen's then. Hence the umbrella term that is quite gets people caught out. The associated psychiatric disorders that may coexist with this would be the obsessive compulsive disorder, depression, and anorexia associated with this. Now, moving forward, to diagnose this condition, if in our case, we got the appendix out first to find that there was hair pouting out from the stump of the appendix. What would you do in people who do not have who do not present with appendicitis? However, they would be presenting with subacute bowel obstruction or abdominal pain. They need to be further worked up. They need to be investigated with endoscopies or scans to be absolutely sure there's nothing, keeping in mind that if there's no psychiatric disorder or there's no predisposing condition there, you might just slightly be aware and rule out as a diagnosis of exclusion. So the endoscopy will obviously be quite helpful to diagnose the kind of bezoar. In our case, we are dealing with trichobezoar, mostly in the stomach, and it has satellites down. In our case, when we discussed and she agreed for endoscopy, luckily she did not have any trichobezoar in the stomach, and hence the scan, the subsequent scan that we ordered for her did not show any satellite in the small bowel. So we sort of were happy in the sense that we have treated the cause there. However, sometimes if you do get caught out and you take the appendix out with this with the hair, which is a very, very rare thing to do, you still need to investigate the cause. You need to do a gastroscopy. You need to do a full small bowel series to see absolutely be sure that there's no satellites between, which we also did. That's how the CT scan comes in handy. It will tell you about the satellites present in the small bowel before the appendix, between the body of the stomach and the terminal ileum. And treatment-wise, obviously non-invasive to invasive, as we've always been taught in medical school. Yeah, why would you want an operation if you could treat something medically? I think the answer there is that you can't treat this medically because there's a problem. The enzymatic dissolution is not possible with these hair. It's very, very difficult. Eventually, with gastroscopy, if you try to remove the bezoar from the stomach, it fragments. You don't completely get rid of it. And secondly, you can't get to the satellites present in the distal small bowel. In that case, you need to do a laparoscopy at least to find out where it is, or a laparotomy, which is the gold standard. Hence, the success rate very, very low, unless there are other bezoars like the plasticobezoar, which is present in the stomach. You can take it out endoscopically with an over tube. That's completely separate entity altogether. Now, what does literature say about now? Gorter and his colleagues reported cases with this non-specific abdominal pain in children, and they were endoscopically. They tried to do some work, tried to retrieve it, as they found it in an acute setting. Now, when we look at the number of cases, there were 40 cases discussed in literature. Only successful were 2 of them, and that was also fragmented. The only thing that is useful, endoscopic retrieval, which fragments the bezoar, not an excellent idea. One of the 2 cases reported there removed 55 grams of bezoar, but again, you are left with fragmentation of the specimen, fragmentation of the bezoar. That means some of it's still left inside. You can't reach the satellites which are present in the distal small bowel, and they eventually form the nidus, and then basically you're back to square one. That needs further addressing. However, endoscopy would enable to differentiate between a bezoar and a foreign body, and eventually you can remove that and make a diagnosis. Moving on, laparoscopy, very popular. Out of the 8 cases reported in literature, there have been 75%, quite considerable success with laparoscopy. The Japanese surgeons have been quite on the ball with it. Narasimha and his colleagues have successfully removed bezoars laparoscopically. Obviously, it's non-invasive, it's less invasive, so less postoperative pain, early return to work, less complications. However, the duration of surgery is quite long. The chances of the satellites can be missed if you're not lucky. And this is pretty much what Najam did. And you can see here the duration of surgery was between 3 hours to 5 hours. So this is a long anesthetic that you are giving the patient. And 2 of these patients were converted by Levy and Clem. And again, converting to laparotomy, which becomes the gold standard. They had their advantages and disadvantages there. However, endoscopically, if you're lucky and you know where it's localized, and you're able to point out and where that satellite is with an MRI scan or a CT scan, you would be able to get around it with a laparoscopy. Again, you make an incision in the belly, retrieve that bowel, take the bezoar out, and anastomo is quite straightforward operation if you get it right and you know where it is. Laparotomy is the gold standard. You've got a lot of success rate with that, slight complications associated with it, which is acceptable. But the aim of this modality is you're getting 100% success with less complication rate. You're getting all the satellites out, you're getting the main body out. It's the considered treatment choice in many, many centers. The acceptable complications, which could be pneumonia, pulmonary ileus, wound infection is acceptable, but it's very rare. But all of these patients get better, and they don't, unless the cause is treated, they should not get another bezoar unless they get help from the psychiatrist at that point. Just to finish off here, Samir Abduzaid in Turkey, he presented 2 cases. Now, this was quite unusual because, and this goes slightly, it came to my attention because they found hair follicles in the stump of the appendix, and the patient did not have any bezoars or did not have any trichotillomania, did not exhibit any of that. However, our patient did exhibit trichotillomania. But this is something that's also been published in literature about hair follicles coming out from the stump of the appendix. So just to conclude, after the operation, there's a possibility of the foreign body obstruction that in the presence of GI trichobezoar should be kept in mind, hence keep it open mind. Additionally, patients suspected to have trichobezoar who undergo appendicectomy should be exercised not to leave hair formation inside. So take the appendix out, take the bezoar out from the stump if you get any, because just very, very few cases of the stump appendix with bezoar formation. But also look at the cause, milk all the small bowel, look at the stomach, which we did with the gastroscopy, investigate the small bowel with a small bowel with an MRI scan of small bowel, which will give you further imaging, and manage the patient with recurrent intentional. Now, the main, obviously, you need to manage the patient with the recurrent intentional foreign body ingestion. That means a team approach would be required, medical, surgical, and psychiatric approach. So collaborative strategies should be in, and these disciplines should help to prevent any issue that is costly and burdensome and for the health system as well as the patient. In emergency situation, you need to do the emergency operation that